So in my first presentation, I would talk about the influence of expectations. And I guess, for you who are working clinically, that is an easy topic because you see that all the time. So you understand when patients come with anxieties, with the expectation that the pain will get worse, and you can see how that directly translates into pain. And I would like to show you a little bit more about what is behind all of that. So what is happening in the brain when people have these expectations, and where the link is between the expectation as a cognitive process and pain as the perception. And we will start with something very, very simple. That is basically the traditional understanding we had of pain for quite some time. And that is, as you can see here, that tissue damage happens in the periphery, and a signal travels up to the brain, and the brain basically reflects what was happening in the periphery, and that is somehow translated into pain. With all the research we've done over the past decades, we know that that is no longer true, or has never been true, probably. The way we see it now is more like that. We certainly have tissue damage very often occurring in the periphery, and nociceptive information traveling up to the brain. But the brain is the key organ that generates the perception of pain. So in short, without a brain, you wouldn't have any pain. Pain is not originating at the site of the injury, but it's originating in the brain. And what makes that so interesting, or why that is critical to your work and the work we're all doing on the perception of pain, is that we have these influences we call top-down modulation. So this is information coming from the brain that affects the way we perceive pain in a top-down fashion. So information are passed on from the brain downwards, and I will show you one example later on where we can even see modulation at the spinal cord level, so very low down, not only in the brain. And just as an idea, it's not the sensory information that gets translated into perception, but there's a key step in between that basically summarizes, at least in my understanding, all the types of psychological influences we see on pain. And there are various. I mean, you've read about them. There's anxiety, there's something we call catastrophizing. So when patients have a very negative outlook on how their pain is going to progress, that they may lose their job, that they may end up with relationships that are suffering from their pain problem. That is something that is a perspective that certainly creates a fear that makes the pain worse. And all of that can be summarized as prior assumptions. So people have ideas about what is going to happen next. So even when you came here this morning, you know what is usually happening at a conference, right? So you would be completely surprised if I would start dancing now, because you wouldn't expect that from a conference on pain, necessarily. So I would absolutely violate that script of what you think should be happening at a conference on pain. And that's the same with perception. So we know, for instance, when we touch a hot stove, that what it feels like. And even if we haven't experienced it yet, we are so knowledgeable these days. Like when you undergo a particular intervention, you can Google it. Yeah? When you see root canal treatment, you Google it and you understand how painful that can be without having ever had one. Okay. So prior assumptions and expectations guide the way we perceive the world, and not only in the domain of pain. So let me just show you an example where that has been quite striking, at least to me. It doesn't have anything to do with pain. I will talk you through it. It's probably a bit difficult for you to see. So what that is, it's a glass, basically, a cylinder with moving dots. And these moving dots move randomly. So you can't tell if they are moving from left to right or right to left. You basically can't tell. Unless you give people spatial cues. And that is exactly what happened here. Let me see. This is what happened here. So in this case, when they used this prism, all of a sudden, these random dots started moving from left to right, okay? And in this condition, they started moving from right to left. And these people learned it. These were all healthy volunteers. So when you put these prisms up in a particular way, you understand that dots are moving from left to right or right to left. What you do while you learn that is you generate expectations about what is going to happen. When you then take these cues away, and that was basically this condition, they actually couldn't tell anymore. But because they had learned previously and they had generated expectations, you can see that although they couldn't tell in which direction the dots moved, they moved more in this direction here to the right when they referred to this previous condition where they had the cue, and they moved more to the left when they used the goggles in a way that had previously been associated with a leftward movement. So we are creating our reality actively by referring and drawing on our expectations, and then obviously combining them with incoming information. So we are not sitting there and we're not completely delusional, so we're not making up something completely, but it's a mix between what we expect, so our hypothesis, and what comes in. And the combination of the two, that is what makes our reality. And I mean, you all know that sometimes this influence of expectations can be very, very strong when you think of beliefs people hold on to, although they have lots of evidence that that is actually not true. Yeah? So all these irrational beliefs we hold on to, although they completely clash with other beliefs we have, and they also clash with sensory information we get. It doesn't matter. We are very interesting creatures. We can still hold on to that and create our environment based on these expectations, although they are wrong. How does that translate into pain? I'm going to talk about a study I did with a colleague and dear friend of mine, Ulrike Bingel. She's German, like I am, and she visited us in Oxford for a year. And she did this study with me and a couple of other people on the modulation of real drug effects by expectations. So you have heard a lot about placebo analgesia, I guess. So a lot about how you can create pain relief simply by thinking you're getting a powerful painkiller, whereas actually you're not. You're getting a sugar pill. Okay? And here we took it one step further. We wanted to know whether that doesn't only apply to something that is completely inert, so doesn't have any active ingredients, but whether that also applies to something as classical as an opioid. So we used remifentanil, which some of you might know. Remifentanil has been around for quite some time. It's a very well-known opioid, and we know exactly what it is doing on all different levels, so it's very well characterized. But in this particular case, we used it under different cognitive conditions. Let me talk you through. So in the first condition, they weren't on the remifentanil, so we just used our thermal pain. So they had a little hot plate attached to the arm, and we would increase the temperature up to a level that was quite painful. Okay? And then they got an IV line, and we told these participants at some point you will get this very strong opioid, okay, and that might do something to your pain. What they didn't know was that while they were still waiting in the scanner, so that was all done with brain imaging, while they were lying in a scanner, we already started the infusion, but they didn't know about it. That is an interesting field ethically, because you have to tell them that at some point they will get the drug. They were just not informed about the exact time point. So what is called no expectancy means they went on the drug, but they didn't have any expectation because they didn't know they were on the drug. Okay? Makes sense? Okay. And then we told them, now we're going to start the infusion. Although the infusion had started already, they were already on the drug. And that is what is called the positive expectancy condition. So, what is the difference between these two? The difference is that they, in one case, didn't know about it, in this case, and in this case they did. But pharmacologically, these conditions were exactly the same. Okay? this negative expectancy condition, we told them, now we have to stop the stimulation, the infusion, and what you might experience is a so-called rebound pain. So the pain might come back, and it might be even stronger than before. If what the drug does is only down to the pharmacodynamics and the pharmacokinetics of it, it should do its job if you want it or not. Yeah? So if you have the expectation or not, it should give you analgesia. But let's see what it really did. These are the behavioral findings. This is pain intensity. It might be hard for you to read. The resolution is a bit poor. This is pain intensity in the different conditions, and these are the anxiety ratings. So the pain rating was pretty high in the beginning, and from here to here, they go on the drug, but they don't know about it. And what you can see here is that the pain goes down, which is great. So that is good news. So if you want it or not, your opioid gives you pain relief. So why do we think it's good news? Well, there are people who can't have expectations simply because they are unconscious, for instance. They might not be able to generate these expectations anymore, and still this opioid would help them. But look at that. When you then tell them, now you're going to go on this powerful painkiller, although they are already on it, you basically double the effect, okay? By telling them, simply by telling them, it's not any expensive intervention. You're just telling them that they are going to get a painkiller now, and you double the effect. And then interestingly, from this condition to this condition, we told them, now we stop the infusion, and you will get off the painkiller, and the pain might come back. And that's exactly what happened, okay? Even though they were still on the same dosage in this condition, they were still on the drug. So what does that tell us? That tells us that perception very heavily goes with expectations, even though you have something as hardcore like an opioid. Yeah? It's modulated by what you expect. And interestingly, so we wanted to know then, is that just a report bias? Do people sort of get a story and rate it accordingly? Or is that also something we can see in the brain? And we could. So regions that follow that pattern are exactly those we would normally see related to pain perception. So they showed exactly this drop from here to here, and from here to here, and then the increase. All of these classical pain regions followed exactly that pattern. Plus, we could also work out who was orchestrating that. So these are the regions that start the modulation, and these are classical regions we see in placebo analgesia, for instance. So they would initiate this modulation and drive the top-down influence of expectations. But what is the underlying mechanism? So you could say that's all interesting. You know, maybe you would even say, I know that, you know, just looking at your patient. So what are you doing all these fancy studies with imaging if we know it already? Okay. And I think that's a fair point. It's a very fair point, because brain imaging has to deliver on something different. And I'm going to talk about the just pretty pictures idea later in the morning. You know, is it just to make all these fancy, really colorful pictures for nothing? Or is there more behind it? Is there something we can really get from brain imaging? You can only get from brain imaging and from nothing else. And I think one of the very few indications for brain imaging is to understand the mechanism, to understand what is behind it. So this is a study we did that is still in the behavioral phase, so that is a behavioral study. We will then take into imaging to see how that is processed in the brain. But I didn't want to not show you the data, because I think they go exactly in the direction I was talking about, to talk about the mechanism. What's the idea? The idea is that of symptom perception as an inferential process. It always reads awful when I look at it. I think, goodness, what does that mean? So what it means is that symptom perception, like the perception of pain or any type of symptom your patients report to you, are not a direct reflection of what is really going on, but it's an actively composed output. Yeah. What do I mean with that? You're still looking at me like, goodness, what is she talking about? Let's say you wake up in the morning with some sort of headache, okay? And you know that you know migraine because you've had it in the past, okay? But you want to work out if what you feel on that particular moment is going to develop into a full-blown migraine attack. Because sometimes you're lucky and you get this unilateral pulsing pain that then goes away and it doesn't give you a full attack. So you're lying there in bed, let's say, and you're trying to work out, is it that or is it a hangover headache from last night? Okay. And what you do is you try to collect evidence so that you can make a decision between these two alternatives. So it's either a migraine attack or it's not a migraine attack. And you collect evidence. So you try to work out, is the pain getting worse? Or is that something like when I get up and have a coffee, it goes away? Is that the classical unilateral pain, or is it more the tension type headache if you're educated and you know the difference between the two? And then slowly, over time, with the collection, with the evidence you get, you wiggle up to one of these borders until you say, now I've got enough evidence to say that is a migraine attack. Okay, I'm fairly sure that is a migraine attack. And you can, if you wanted to quantify that, you could look at the response time, so at the time it takes you to come to that decision. And interestingly, if we're very good with detecting migraine attacks, we get faster with that. Okay, we don't need to lie there for 10 minutes, but we know after a minute or so that that's it. You know, I know that, I recognize that. And the idea is that when you have these prior expectations, so when you know what a migraine attack is like, there are basically two ways you can speed up that process. Or if you translate that into an experimental context, where it's not about a migraine attack, but let's say you give people a high intensity pain and a low intensity pain, how long takes it for them to work that out, which one that was? What are the two types of bias you can have? One is a type that is called bias in sensory processing. So simply because you know how the whole story goes and that you will end up in bed throwing up, the classical migraine, you collect the evidence and process evidence faster on a sensory level. Okay, so that will really speed up the way you process incoming information. The way that translates into our model is you don't need that much time to wiggle up to that line, but with the improved sensory processing, you need less time because your slope is a bit steeper. Does that make sense? Okay. A completely different bias from that is what we call a decision-making bias. So if you're lying there and you're trying to work out if you're getting a migraine attack, you could also not start at the neutral point between these two boundaries. So you don't necessarily have to start here, where you would be exactly between these two boundaries, but you could move your prior up from here to here, okay? And then with the same slope, you would need less evidence to reach that boundary. That's a completely different type of bias. It doesn't have anything to do with sensory processing. It's just the way you categorize and process information afterwards. Okay? Why are they so different? Well, the classical view is that when we have an influence of expectations, that the sensory processing changes. So we're always looking at areas that process hardcore nociceptive information. So we would look at the thalamus where information comes in. We would look at S1, the region that is involved in the localization, in the determination of the quality and the intensity. But we wouldn't necessarily look at regions that are higher level, so higher level cognitive areas. Plus, it could also mean a lot when it comes to the clinical work, because what we see here, a change in decision making, means that people are jumping to a conclusion without necessarily processing all the available information properly. Yeah? So think about your patient, and you introduce a certain type of movement. So you say, it would be beneficial for you if you could do this or that exercise. And your patient goes, I know that, that's painful, I'm not going to do that. So he jumps to a conclusion without actually having experienced it. That is very different from him going or her going through that whole process and experiencing that is really painful. So there's a huge difference between the two. And the question is, what is it actually? What do we get? Which type of bias do we get with expectation? Is it either the gain control or is it a decision-making bias? So we did a study on that. This is how you differentiate the two, just briefly. Where the response time for the drift rate, for the change in sensory processing is faster. So you can see from here to here, you get very, very quickly. Whereas when you've changed your prior and moved up in the wrong direction, but you have to correct your expectation, it takes you much longer to get to that incorrect boundary. So that is basically how you can tease the two apart. So what did we do? The design we used was very, very simple. These were all healthy controls, no patients. They got 2 cues. One cue told them, that is this one, the square in this case, obviously that was randomized then. But let's say when they got the square, they knew in 80% of the cases they would get a high intensity zap. So really nasty, painful shock. And only in 20% of the cases, they would get a low intensity one. But when they saw the triangle, they basically couldn't tell. It was 50-50. Both outcomes were equally likely. And then they got either the high pain stimulus or the low pain stimulus, and they had to say, by pressing a button, as quickly as possible, that was high pain or low pain. Okay? And obviously, in this condition, when they had prior information that high pain was more likely, they were more keen on saying that was high pain stimulus. Okay, so we induced prior expectations that changed the way they perceived the pain. But what type of bias was it? That was the first experiment. So we had the 80-20 and the 50-50 conditions. You can see that here again. And then we had a fantastic reviewer. There can be a total pain, but this one was really, really helpful. And he said, why don't you include another condition where you also cue them towards low pain? So where low pain is very likely. And that probably translates to a condition like when you put people on an intervention and they expect the pain to go down. What type of bias do we introduce there? Outcome measures were response times and decision accuracies because we knew what we applied, high pain or low pain. And this is what you get. This is the first experiment, and you can see the starting point, change in starting point. So that is the decision-making bias, and 0.5 would be the neutral starting point. That would mean, I think both outcomes are equally likely, high pain or low pain. But what you can see here is in the 80-20 condition, so when they expected high pain, they do indeed shift their prior up. They don't start at a neutral point where they really, in an objective way, collect the evidence, but they're already expecting high pain, so they need less evidence to wiggle up to that line where they would say, that is high pain. So they would jump to that conclusion without actually having the evidence. Same for experiment 2, where we also had a 20-80 condition. It works both ways, which is very interesting and potentially, I think, very relevant for the work we are doing. So you can see when I don't have any information, they're about on that 0.5 line, so they are really neutral. If they expect high pain, they shift their prior up towards the boundary that would be high pain. If they expect low pain, they shift their expectations towards low pain. Nothing is happening on the sensory bias. So the drift rate was all over the place, but it didn't change sensory processing. So taken together, what do we learn from this experiment is what we learned from this experiment was, but it doesn't necessarily shift sensory processing when you have prior expectations. It changes the way you judge stimuli. It changes the way on a higher, you perceive and experience these stimuli on a higher level, and the way you classify them. So if you go back to the migraine analogy, it's much more likely that you say, with very little evidence, that is a migraine attack. I'm absolutely sure that is a migraine attack, even though you might not even be able to say that yet because you don't have all the evidence. Okay? And interestingly, we saw very unexpected correlations with psychological traits. So one of them is anxiety sensitivity, and that is actually the fear you experience to have anxiety-related symptoms. So it's not just the anxiety itself, but that you really feel uncomfortable when you experience anxiety. And interestingly, people who score high on this questionnaire, it doesn't matter so much when you really expect pain. So both the high and the low anxious ones, your anxiety sensitivity participants, moved their prior up from this neutral line up to the boundary where they expect high pain. So that's quite normal. You have the information, it's very likely that you will get high pain, so you do expect it. Okay. But interestingly, the ones who scored high on that questionnaire already do that when they don't have the information to do so. So in this 50-50 condition, the outcome was completely random. It was 50-50. And still, these participants would already, in anticipation, move their prior up towards that more awful outcome. Very interesting example. It was very different for people suffering from a mild form of depression. When I don't have any information, none of them was particularly fast in sensory processing. But those scoring high on depression processed information even faster when they expected high pain. So here we see an influence on sensory processing, but that went with depression as a psychological trait. Okay. So when we say decision-making bias, what do we mean? Do we just mean it's a report bias? Do we mean they are just telling us something in order to fulfill our, whatever our hypothesis was? And I just want to point out that it's very different from a reporting bias. So in reporting bias, you have perception first, and that is finished, and then you change the way you report your pain, right? Because you think your experimenter wants you to feel less pain or more pain. With the decision-making bias, that's different. In decision-making bias, the bias is part of perception itself. So you can't disentangle what is perception and what is the reporting. They both go together. That is a very important step. Okay, let's leave that behind. What does that all mean for therapeutic approaches? And I think that is very critical because up to now that was sort of very sciencey and academic, and you think, what are they doing? But I think it has direct relevance for what we do. And when you see patients, you might want to have that in mind. I think the interesting parallel is that symptom improvement can be seen as such an inferential process. So let's say you get patients coming to your clinic and you put them on an intervention. You start doing your training with them, you start whatever it is you're doing. What do they do? Well, these patients try to work out if you can help them. Okay? So do I see that my symptoms get better or not? And that basically follows the same process. So they try to collect evidence for one or the other. So they go home and they start doing the exercises you gave them, and they would observe, does it make my pain better, or does it get worse? Or doesn't it do anything? So what does it mean when it doesn't do anything or when it gets worse? They might not come back. They might switch to somebody different. They will try to look for help elsewhere. And the difficult bit is that maybe whatever you wanted to do to them could have helped them, but that intervention didn't get a chance. So you think, goodness, if they had come back 2 more times, 3 more times, they would have seen an improvement, but they don't. They don't come back. And that is basically because it's following this very same process, and here, the time it takes them to reach that boundary, which you can see as response time, is critical. We know that from psychotherapy, that there's only a certain time window in which you have to bring about change for people to come back. If change doesn't happen within, and you only have very few weeks, we're not talking months or years. If change doesn't happen within that period, it's lost. And I will tell you later on how lost it is. Yeah. It's not just it's more difficult or I have to make more effort. It's doomed, it's gone, the chance. The window has closed. And we're trying to work out why that is. And it comes down to this inferential process. Let me show you why. So when people come with these expectations, they come with a timestamp or with an expiry date. So you only have so much credit, right? And you can use it up or not. And I'm absolutely assuming that you're doing your very best. I'm not saying it's anybody's fault. I'm just saying that if we are aware of it, we could plan our intervention differently, and if we would understand with the knowledge from brain imaging, for instance, what type of evidence individual people need to hold on to something, we could tailor our treatment in a much better way. Because what happens when you violate expectations, so when you don't meet the expectation, is the brain generates a signal. You can see that. We can see that when we do fMRI. It generates a signal that tells you there's something wrong here. So the expectation I had wasn't met. So when we translate that into the treatment context, they do your intervention and nothing happens. The brain would start signaling, you don't need to go there anymore. Obviously, that's the interpretation. The brain doesn't do that. But the brain would generate a signal that says, your expectation that that guy or this lady will help you is wrong. Okay? And the problem is you will revise your expectations. So how does that go? That is very much in its infancy. So I'm talking about ongoing research. I can't give you the magic formula. I can't tell you when somebody with ginger hair comes in, you better do it within 2 weeks or so. So we're not there yet. But the idea is to find out how people hold on to expectations, how they revise them, and how they let go of expectations. So how does that go? This is just an example. So let's say in a placebo paradigm, you can replace placebo by your intervention. You apply that here, and what is happening, or what people expect, by whatever means, is that the pain goes down immediately. Okay? And ask your patients about that. What do they expect? When do they think the pain should go away? You would find very often that that's the timeline they expect. The second they leave your office, here you go, the pain is gone. But you all know that is rarely the case. You might be lucky, but that's rarely the case. So let's say the pain goes on for a bit longer. And this could be anything. We all know that. It could be days, it could be weeks. If it's really bad, it could mean months. Okay, but what is happening during this time is that the brain starts is picking up on the discrepancy. It's picking up on that difference between what I expect and what is happening. So every day, these patients wake up and feel nothing has happened. This prediction error is growing, and it's telling them to revise their expectations. So you can see here, over time, the discrepancy gets bigger and bigger because on day, let's say, 10, let's say this is day 10, they already expect it to be almost pain-free. But because your intervention takes much longer, they don't hold on to it. And then at some point, we might go into that cutoff where nothing is happening anymore, and they revise their expectations. So the prediction error is growing, and their expectation, which was pretty high in the beginning, levels off and goes down to 0, so they can't hold on to it. Why is that important? Let me tell you about this study we published in JAMA Internal Medicine last year. And it was down to the observation we had. We do meet a lot when we see patients, which is, when we ask them what type of treatment have they had, they go, oh, I had that, and also that, and that, and that, and they come with this huge list of things people have tried on them. And you wonder, based on what I've just told you, on this revision of expectations, if these later interventions still had a chance, or whether everything was lost already by the time, they started the 20th intervention, simply because they didn't expect to get anything out of it anymore. Okay, so what did we do? That was an experimental study, again with brain imaging. And what we did was we created therapy success, which is great. So it would be great if we could do that, wouldn't it? So what we did was we lowered the temperature of a thermal stimulation from 80 to 20 when we told them they would go on an analgesic treatment. So what they felt was, that's brilliant. This stuff is working. So this treatment they got was fantastic. In the negative treatment group, it was exactly the opposite. So they got an 80 out of 100 on the control side, and they also got an 80 out of 100 on the side where they actually expected analgesia. So the experience they had was that this analgesia isn't working. I don't get anything out of it. Okay, that was on the first days, day 1 and day 2, and then we told them, forget about that treatment. We would try something different, which I think is what happens a lot in daily practice. We just switch the treatment. So let's try something completely different. And in this case, we lowered the temperature to a medium level. So we lowered it slightly in both groups, and we wanted to know whether the group with a positive treatment experience has the same outcome than the one with a negative treatment experience. And that is what you see here. That is pain reduction here in the positive treatment group and in the negative treatment group. Physically, they got exactly the same stimulation, but the group who had had a positive experience in the past could carry over to the next treatment and would also benefit from the next treatment, while the other group couldn't. Yeah. So if you get disappointed once, it's really difficult to get the motivation and the expectation up and running again to support whatever type of treatment you're going to help them with. And interestingly, it's not a report bias, and I'm mainly using these brain images here to support that and to show what is behind all of that. And we will go into that more in my second talk later on, when it's about the idea that it's just pretty pictures and if there's more to it. But you could also see modulation in one of these areas that would process nociceptive information. The incoming information that would be processed differently depending on your prior experience. Okay? So what that means is you probably don't have 20 trials. You don't have this other chance. I'm not saying that to scare you, because I know that you're always trying to get it right. But it's worth asking the patients if they've had 20 or more tries in the beginning, because that is what you're dealing with. You're dealing with a massive package. And very often, when patients come to you, you were last in line. So doctors have tried a lot on them, and then only once nothing has worked, they get to see you. And to be honest, it's even worse for psychologists. So when I talk to psychologists, they would always nod and say, yeah, I see these cases that are really absolutely hopeless because everybody has tried everything on them. It's important to know, ask them. And when you explain a treatment to them, ask them if they really believe in it. Do they think that could do something? Or is it just another one? Just another one I have to do because they have to tick the boxes. So perception as inference, I just want to tell you how we see it, and it will be quite confusing. Don't try to get into that. It's a whole model behind that that is trying to, I'm just going to show you the full model, just to show you the essential. That is what I'm working on. That is my project for the next 5 years, is going to look at whether you see a confirmation or violation between what you expect, that is what is called the template here, and incoming information. Is that the treatment hope you have met by what you experienced? Is that met by the decrease in pain you were hoping to get or not? And then the question is, if it doesn't meet the expectations, does the brain pick up on that? So do you generate this prediction error? Does the brain understand that that's not what it wanted? And sometimes you also get these patients who are incredibly tolerant, who rarely get any benefit out of them, but out of the intervention, but they would still hold on to it simply because maybe their brain doesn't generate a prediction error because it doesn't understand that there's a difference between the expectation and what they get. So that is another option we haven't spoken about. And then the question is the prediction error followed up? Do they update their template or their expectations? Or is it not followed up? And would they hold on to it even though they think it's not right? I want to leave you with that for now. And then, as I said, I will be talking about the value of brain images later on in that context. It won't be a completely different topic. I will pick up on that and we will continue from there. But just have in mind, I think that's the key message, that perception is more than just the processing of incoming information. It's an active composing process where you actively integrate not only sensory information, but prior information and expectations you have about what you're going to experience. And I would like to thank you for that for now. And I think we take questions after the morning session, right? Thanks.